This is Dr. Beall. Since 2005, Dr. Beall has been the Chief of Radiology Services at Clinical Radiology of Oklahoma in Oklahoma City. Dr. Beall received his MD from Georgetown University School of Medicine. He is a board-certified radiologist. He served on the board of directors for the American College of Radiology, and he has more than 160 publications. Currently has a lot of research projects going on. So thank you, Doug.
Absolutely, Ramo. Thanks a lot. Okay, so we are here doing hip radiofrequency ablation of the sensory nerves to the hip. So we have got sensory nerves that come from the femoral nerve and sensory nerves that come from the obturator nerve. So we're going to do two separate areas of ablation. And we use a needle that has a 5.5 millimeter active tip. And this is cool RF. So it's cool RF because the temperature is 60 degrees at the tip, but the tissue has 80 to 85 degrees of increased temperature. So we're going to get the cool on the tip, makes an elliptical lesion. Instead of the typical lesion along the longitudinal axis of the needle, this is an elliptical lesion that goes 2 to 4 millimeters beyond the distal tip of the needle. So it goes all the way to the bone, even though the tip of the probe is not on the bone itself. And we are going to do the primary hip radiofrequency ablation concerning the femoral and obturator nerves right now. As you'll see from the image here, the real trick on this is to get an AP image, direct AP. And so we've got a reasonable AP image with the ischium on FOSS. So the first order of the day is to mark this, the 12 o'clock position on the acetabulum, the supraacetabular ilium will be our target. So we're going to start just lateral to there. This cadaver's quite thin. Start just lateral to there. And we're going to march up until we are at the 12 o'clock position right there, 5 millimeters above the joint surface. And so this will get the femoral branches of the femoral nerve to the outer portion of the hip capsule. And so typically we will do one lesion here, and then we will pull it proximally and do one lesion right there around the 12 o'clock region of the supraacetabular ilium. And before you do this, motor testing needs to be done at 2 hertz, 1 to 2 volts to make sure that you're not stimulating the femoral nerve. Because as you know, the femoral nerve is incredibly important. So the femoral branches to the hip capsule are the ones we're ablating. These are sensory only. But the branches of the femoral nerve are different than the femoral nerve itself. And if you get motor contractions during motor testing, you need to reposition the needle. Because if you RF the femoral nerve, both you and the patient will hurt greatly, because as you know, femoral nerve innervates the quadriceps muscle, so they will not be able to walk. It's incredibly important. The other area of radiofrequency ablation for cool RF at the hip is right there. So this pathway, along with the incisura or the teardrop, is best accessed farther down in the ischium. So we love bone, and our access point is primarily right here. And so we're going to start here. We're going to come down to the ischium. And our target will be right here. So I feel bone. This is one target right here. I typically will make another lesion just superior to that. Right. Should be right here. And I make one lesion along the incisura or the teardrop. I'm going to pause right here and comment on the neurovascular bundle. So the femoral artery that comes down here will come down about so on the femoral head. You can see the superficial femoral branches. I'm going to refer to the screen here. So this is calcification from the superficial femoral artery. The common femoral artery come down here and will branch into the superficial femoral and the profunda femoris. And it always will be located on the medial 20% of the femoral head. So for those of you who've done any type of vascular work, you can target the femoral artery by coming right here. And so you see the femoral artery would come down here and will come right down here. So you need to make sure and have your approach right here to avoid this. The femoral neurovascular bundle will be located along the medial portion of the femoral head, so just stay away from that. The other target will be the teardrop or the incisura, and this is located right here. So you can come down directly on that, taking care not to get too medial because you want to avoid the femoral neurovascular bundle. And on the study by Rivera that showed the efficacy, one of the initial studies, they had 4 hematomas and indicating injury to the neurovascular bundle. The other method that you can do, so this will probably be a reasonable position, and it is. So you want to make one lesion there and one lesion where the other needle is. If you are concerned about the neurovascular bundle with the incisura, you can take the approach of putting a marker needle at the bottom of the teardrop or the incisura. We will use this as a marker needle, and I'm going to come lateral and meet this needle coming under the femoral neurovascular bundle, because if you think three-dimensionally, the femoral neurovascular bundle is easily palpable because it's right under the skin. Typically, it's about 1 to 3 or 4 centimeters in, depending on the size of the patient. So we will start laterally, and we will go under the femoral neurovascular bundle to meet the other needle. There we go. And we just will walk up because the incisura will be located more anterior than the previous location along the ischium of the obturator branch. And I can feel the teardrop here, and I can meet the needle. I feel I have a metal on metal needle. I'm just going to go slightly superior to that. And there's the other location. So this is 2 separate ways of getting at the bottom of the incisura. And 5.5 millimeter active tip, the size of the lesion will range up to 8 millimeters. And this is a way to ablate the obturator branch, capsular branches. The other capsular branches that go to the posterior portion of the hip will be from the sciatic nerve, which is obviously a no ablation zone, and from articular surface from the superior gluteal nerve. But these will get branches along the 12 o'clock position of the supraacetabular ilium from the femoral branch, and the obturator branch along the inferior portion of the teardrop and the ischium portion. And this ablation is carried out at 60 degrees Celsius for 2 minutes and 45 seconds. Really, it's a 2 minute and 30-second burn, but at 2 minutes and 45 seconds for a ramp-up time. Again, the soft tissue temperature is about 80 to 85 degrees. And that is RF, cool RF ablation of the hip.
Thank you, Doug. Hey, Doug, how did you get that first image? What kinds of things did you look at to ensure that everything was lined up the way you
So if we can come a little bit more midline, pull toward you. And the first thing that you need to do, just slightly more, is the key for positioning is to have just a little bit more. Obturator foramina need to be symmetric. And so this is only, this is not a whole person. So our angle and our trajectory of our C-arm is a little bit off. I'm gonna come back a little bit, caudal. Yeah, good. And so this would be a little bit more of an ideal AP image with the obturator foramina being symmetrically located. And then if you pull back toward me, this is an even better position because you can see you have a more en face view of the ischium. And so this is a more ideal approach. The C-arm is off kilter here. It's a lot more caudally oriented than typical because it's just a partial cadaver, it's not a whole person. And so the targets, again, are along the ischium, superior ischium, just inferior to the joint, along the inferior border of the teardrop or the incisura, and the 12 o'clock position along the supraacetabular ilium, just 5 millimeters above the joint surface, joint line.
Looks great, Doug. You know, you're an interventional radiologist. You have X-ray vision, and you're pointing out vascular structures just looking at fluoro. Is there anything else you do to look at or to figure out where the vascular structures are?
So the neurovascular structures, if you're really concerned about this, I would target this routinely just under fluoro. For people that are very difficult to feel the pulse, you can target this, and it's located right over the medial portion of the femoral head. This is one of the things that's really reliable in human anatomy. If you're concerned about it, use ultrasound and go, again, the neurovascular bundle is more superficial. So by targeting the inferior portion of the teardrop, I can go lateral and go under and hit this needle, and by going under the neurovascular bundle, it's very superficial. So if you're concerned about it, one of the other ways that you can stay safe is by starting on bone and marching up very medially. So we can start at the tip, the inferior portion of the ischium, and then march superior. You can start here. Let me just deal with one needle. And march superior from here. Right there. Or over here. I can feel bone right here. That's our target spot. And as we can see the whole time, we're starting off in the inferior portion of the ischium, going superior to our target area, and it keeps you away. This portion of the ischium, the superior portion of the ischium, will be more posterior than the inferior portion of the teardrop. So you have to come ventral or anterior about 1 centimeter to 2 centimeters to come up the hill to get to the inferior portion of the teardrop. You can see the calcification right here. This is the superficial femoral artery. So we're a full centimeter away from this. And also, by the time you start here and hit bone, you'll be about 3 centimeters on most people deep to the neurovascular bundle. So you won't need to worry about that.
That looks great. And that's generally my approach as well. How many of you are radiologists? Excellent. How many of you are anesthesia background, anesthesiology? NPM&R, neuro, internal medicine, psych, ER, psych? Awesome. Anyone else I'm missing? Got everyone? Okay, cool.
So, Ramo, I have one more comment.
Yeah, please.
I made a big deal about the cool RF. It's just that you get an elliptical lesion around the needle. It's more of an elliptical lesion around the needle rather than just kind of along the longitudinal axis of it. And this is made by a company called Avanos, formerly Halyard, formerly Kimberly-Clark, formerly Baylis. I'm waiting for the next name change. It's impending, almost certain. But the reason why I use cool RF on this is just the lesion size. It's bigger. It's cool at the tip, but the temperature is 80 to 85 degrees. It's neurolytic. It's will definitely damage everything but the perineurium on the nerve. So
I think the next name is Beall, actually.
Exactly. Doug, we pass around the lesion model so they can see that it's that spheroid lesion and that the traditional RF is that.
Exactly. So it gives you a bigger pathway, bigger ablation zone.
You had a question, yes.
I know this name, I'm just curious. What about targeting the greater trochanter, walking into the neck and getting the femoral accessory that way?
You could. There are a lot of approaches. So, Doug, the question was starting at the greater trochanter and then heading over from there.
Ramo, can you say that again?
Sure. Or do you want to ask the question?
For the femoral accessory.
For the femoral accessory, could you start over at the greater trochanter and then work your way over?
So for the femoral, let's come superior a little bit. The femoral is probably the easiest to do. So you can start directly lateral, and just this is, you can see superior this is the ASIS, right? And this is very easily palpated. And if for those patients that are larger than this, you can actually start directly over. And so if you want to start here and go directly down, that's absolutely appropriate. Because when you take the needle out and you put the RF probe, it will give you about a 2 millimeter gap. The RF probe is offset proximally. The thing that's different about cool RF is it propagates distally about 4 millimeters, so you'll actually have quite a bit of burn distally. So if you want to, if it's hard to palpate and start lateral like I demonstrated previously, you can come straight down on this and get an adequate burn and a big lesion size. So in patients that are obese and patients that are otherwise difficult to target due to anatomy, you can certainly do it that way.
Are you able to put a probe in, Doug, so we can see what it looks like with that radiopaque marker?
I didn't get that, Ramo.
Are you able to get a probe, a cooled radio frequency probe, so we can see what it looks like?
Yes.
Awesome.
So here is the needle, and the active tip is here, silver part of it. The depth marker is green, and we take the internal stylet out, put the probe in, and the probe locks down like this, and I will show you X-ray view of it. Let me do this. So here's the probe with the marker. So this is the marker, distal tip. The ablation zone is an elliptical shape around it. So this is what a probe looks like. This connects to electrical generator. This connects to the water, and you have water, cool water circulating through the tip. This is what makes this, the tip cool, but the tissue around it still is hot, 80 to 85 degrees.
This is an important point I want to emphasize. Because it's called cooled radiofrequency ablation, it gives you guys, it gives patients, it gives other doctors the idea that it's cold or frozen. Like I still have my surgeons who are like, yeah, do your cold cryo thing. And it's like, cryo is not approved actually, it's not covered, right? We've had studies with cryoanalgesia and it's not very good as far as outcomes. So you really want to make it clear that this is a thermal, burning hot lesion. The only cooling part about it is the circulation of fluid, as Doug pointed out, and it disperses the thermal energy outward, and that's where you get the larger lesion size.
So I probably would go ahead and put in your dictation you're lesioning this at 80 to 85
exactly.
degrees.
So I always put the temperature as well.
When you do pulsed RF, it's down to 42 to 45 degrees. This will still be neurolytic, and will still have a function of probably modulating the dorsal root ganglion. This is not paid for, so this is separated out. You don't want to get into the territory of having pulsed RF, 40 to 42, or anything that's cool, meaning less than 80 degrees, because this only the tip is cool. So go ahead and put in your dictations that the lesioning temperature is 80 to 85 degrees. That will help people separate out from what's typical conventional RF versus pulsed RF. There's typically not. Our European colleagues and our Asian colleagues do lots of pulsed RF, and there's a lot of utility to that. This is not pulsed. This is conventional radiofrequency lesioning. The purpose of cooling the tip is to get a larger lesion size.
That's an excellent point, Doug and Ramo, because when I was first doing this procedure and any cooled RF types of procedures, to note that, yeah, making sure you're putting it is a thermal ablation for billing purposes, whether it's the hospital doing your billing or if you're in private practice, or else you're going to get quite a problem with the insurance company in fighting that actual payment for that actual procedure. So that's an excellent point.
Yeah, it's just a fine point, but it's also one that is extremely important. So I do some pulsed radiofrequency for different reasons. I'll get paid on almost none of it. So just go ahead and know that it's cool RF for a bigger lesion size, and make sure you have the tissue temperature in your dictation as such.
Doug, we have a question.
Yes.
Would you ever attempt the hip with just traditional RF rather than going straight full RF?
I'll ask Doug. Doug, the question was, would you ever do this procedure with traditional RF instead of cooled RF?
I've done this procedure a lot with traditional RF. And I've done genicular nerve, knee sensory nerve ablation with traditional RF. I've kind of migrated to using almost all, or essentially all, in at least the last 2 to 3 years of cool RF. It just gives me better results. I do knee, 8 out of 10, hip 2 out of 10, so 80% for extremities. I do knee the most, hip the next most commonly. But for traditional RF, even using the big ablation zones, some of the techniques, the bifid needles, the larger gauge needles, it gives you a larger burn, but I find that I just have better results, meaning more patients respond. I get about 85% response in the hip and a little bit more than that in the knee, and I think that's about as good as I can do. Literature says it responds a little bit less optimally than that, so more in the range of 70-75% of patients will respond. But I do multiple burns even with the cool RF. So I get a wide swath of territory. I do 2 burns, just like I demonstrated here. So 1 burn at the incisura, 1 here, and then 1 more superior to that, and then I do 2 along the superior portion, along the supraacetabular ilium, 1 just to the right of 12 o'clock, 1 just to the left of 12 o'clock, right there. So, you know, I'm real fastidious about it, but this is, you know, we make our success 1 patient at a time. I really want to give it more than just the good old college try. I want to make sure and get exactly the right area, big swath of territory. And the reason I migrated over to cool RF, it's just improved my results, and I do measure those. We're in 2 different research projects currently. And I think the reason we get better results is probably the greater size of the lesion.
Yeah, and I agree, Doug. I use cooled RF for all major joints. So in addition to knees, hips, and I'll even do suprascapular for shoulder, sacroiliac joint. In fact, there's a review of the evidence supporting the use of cooled RF for sacroiliac joints. And I think the major reason for that is, I don't know who has the model right now, but Doug's made mention of this already. The lesion projects distally from the tip. And so if you are touching down on the 9 spots along the sacroiliac joints, you're going to create a lesion. Whereas with traditional RF, the tip, there's very little, it's pinpoint. So the only way you can actually create a lesion on the nerve is to be perpendicular. And so, yes, you can use simplicity, but I really like using cold RF for the sacroiliac joints.
So most salient paper here is another one by Leo Capral that has, you can go from about a 7 out of 10 to about a 2 or 3 in terms of pain reduction. Also, they use ultrasound. They use ultrasound and the method that I described to go around and under the neurovascular bundle. I think that's not necessary if you keep in the right position, but it's up to you whether you want to use that to so not to injure the neurovascular bundle. Also keep in mind that we purposely stick the femoral artery all the time to do heart casts and peripheral vascular angiography, et cetera. So if you do happen to do this errantly, don't panic. Just steady pressure with your fingers and over the artery and hold it for 10 minutes, and the person will do just fine.
It's a great point, Doug. So you pointed out the acetabular hip procedure. Who are the patients you're seeing? What kind of indications are you seeing?
So the indications for this are primarily hip pain that's not responsive to conservative management. So analgesics, rest, physical therapy, patients, and we have about 7% of women, 10% of men that have symptomatic hip arthritis beyond age 50. It's not unusual to have a person that has multiple comorbidities that either doesn't want to or can't undergo a hip replacement. So even after a hip replacement, you can do this. Just same as with genicular nerves. If you have, for knee replacement, we have about 15% of patients with persistent pain after knee replacement. Hip is far less. It's in the range of 2 to 3%. But there are lots of people having hip and knee replacements, so this is another primary indicator. So people with persistent pain after arthroplasty, people who don't want to go undergo an arthroplasty or can't because of comorbidities, people that just elect, once they fail non-surgical management and conservative management, would rather have sensory nerve deactivation. So these patients are quite common.
Those are great indications. And I used to do pediatric pain at UCSF, and we had a number of individuals with SCFE or AVN or tumor progression to their hip joints, and this procedure was amazing for them.
Absolutely. It's not about a hip replacement. It's about the third or fourth hip replacement. You don't want to start doing hip replacements with somebody that's young, because even like a good set of radial tires, the joint arthroplasty will wear out. And it's not about the initial arthroplasty. It's about the revision, the re-revision, and the re-re-revision.
And there's talk about using this procedure pre-surgically to reduce the incidence or development of chronic pain.
Right. I also, one of the finer points too, I will inject, I inject 80 milligrams of triamcinolone in divided doses, and I do that with 0.25% bupivacaine, and I do that to try to get rid of neuritis that sometimes accompanies this. Anytime you do radiofrequency ablation, sometimes you can get neuritis. It's accompanied by dysesthesia, allodynia, et cetera. So I use a little bit of anti-inflammatory steroid. It helps reduce the incidence of post-RF ablation neuritis.
Any questions? Are any of you doing this in your fellowships? UCSF, Doug's fellow. Excellent. I think it's, again, a lot of what you're hearing about are kind of newer procedures. I think it's an important one to learn, because there are a lot of applications, as Doug mentioned. There's thousands, hundreds of thousands of Americans having knee replacements and hip replacements. I work in an orthopedic practice, so I do a lot of these procedures. Whether you're putting off surgery, or you're getting them off of opioids, or you're improving their post-surgical experience, it's a very rewarding procedure.
People with arthritis tend to be older and heavier, and there's no shortage of either one of those two populations in the United States.
Anything else? Any other questions? Totally clear?
So, Ramo, we're going to go right into a little surprise here. We're going to go into the knee.
Okay.
And we're going to move down the fluoro to the knee. We're fortunate to have a cadaver having a knee there as well. It's great. So, Doug, if you and Ramo, you want to go over the knee ablation, please.
Absolutely. So while Doug gets that ready, again, I do personally way more knees than I do hips. I see a lot of post-arthroplasty pain syndrome patients. You can look at the Spencer-Lew data. You can look at studies out of Europe. I can't remember the authors right now, but approximately, depending on which study you look at, 10 to 18% of patients after a knee replacement 6 months or beyond their surgery will have pain. So it's so important to have options. And most surgeons don't recognize this, right? At their 6-week post-op follow-up, they check x-rays, and they're like, you're good, see ya. The patients are sitting there going, I still have pain, or you never addressed my pain. Being able to have this in your armamentarium, I think, is extremely important, because historically, it's just been intra-articular injections or drugs, right? Or maybe you tried some topical stuff. Now you have something that can give 6 to 12 months of relief. You can repeat it. It's an outpatient procedure, and it's highly effective. So we do have great data for the knee from Tim Davis in Southern California, who compared intra-articular steroid knee injections versus cool radiofrequency ablation of the genicular nerves. I think what was most impressive about the data was that for the genicular neurotomy, nobody did worse. Nobody was worse for having that procedure. Whereas about 10 to 20% of patients after their intra-articular steroid injection had worse pain after that procedure. And if you haven't seen that, you will. About 80% of patients met the threshold of a 50% reduction in pain after the neurotomy. So again, outcomes are good and they're sustained. So we tell people 6 to 12 months. I have patients who I did this on 4 years ago who are still doing great.
Okay, so genicular nerve RF. So our targets here.
Hold on, Doug. We don't have a feed. Give us 1 minute. Not me. Don't show me.
Okay.
All right, we got you.
All right, so genicular nerve RF. So our targets will be the nadir of the metaphyseal cleft. So let's see. So I'll do it just like this. So here's one needle. You can see I'm aiming toward the very bottom of the metaphyseal curve, right? Exactly right there. And so we're going 50 to 60% across the shaft of the femur on the lateral view.
How did you line up your first image there, Doug? Sorry.
So we try to get it as AP as possible. You see the patella is kind of right in the middle, and we are just directly AP. And so our
Patella will be
targets will be, can you guys see this screen?
Is there any way you can,
Okay.
is there any way we can lighten up that image?
Okay, our
You can't see the
targets,
patella very well.
we'll just do this under fluoro, no problem. Our targets will be the lateral portion of the femoral genicular branch. The medial portion, the target is right here. And I'll go ahead and place that needle.
Can you switch that fluoro image over here, because I'm not that tall? And I'll point out what the targets are.
And so that's the second target. The third target will be, well, at the medial border of the tibia. And I will place that, thank you, right there.
So he's finding the junction between the metaphysis and the
Right
epicondyles.
at the bottom of the metaphyseal flare. And our fourth target will be right at the metadiaphyseal junction of the femur. And down a little bit, right there in the center.
And this is,
Fourth target.
you can map out 8 centimeters from the joint line itself, or you can just arbitrarily find your lesion size somewhere in this runway here.
On this, I'm going to come directly lateral. This person is very, very cachectic. So you can go around the quadriceps tendon this way to put the needle in the right location or directly down on it. So somebody that you're concerned about the quadriceps tendon, you don't want to lose style points for going through it, you can just go lateral to it and place the target there. So our targets are right here. So the lateral I'm happy with, the medial I'm happy with on the femur, the genicular nerves, and also the tibial medially. So does anyone know why we don't go laterally in this location down here?
And what's important about that nerve?
Because that's where the common perineal nerve lives. Patient will have foot drop and will not like it at all if you do that to them. And this is the location of the common perineal nerve right there. So these are the targets, and let's swing lateral to get the appropriate depth if we could.
So Leo Caparel did a lot of the cadaveric and physiologic work on figuring out which branches provide sensory-only information to the knee. Okay, so you're catching branches of the tibial, the peroneal, the saphenous, and even from branches coming up higher up the femoral, and that's what that fourth needle is that Doug placed.
This is going to be, why don't we take it up a little bit like this, and we have the other knee here, so I'm going to rotate this one.
What's important on the lateral is to make sure your condyles line up. So you can see they're a little bit askew, and it's hard for Doug because he's got, he's rotating the leg, but make sure on your fluoro that those condyles line up. And what I mean by that is creating an eclipse of those condyles between the left and right sides, which he's doing right there.
Okay, there we go. So we'll rotate the condyles until it's right there. And they're lined up posteriorly. And now our depth needs to be 50 to 60% across the femur. About right there, and also the tibia. And then we will come back around and take an AP shot. That's the appropriate depth, and then coming back around to ensure that you're in the right location. We'll make small adjustments here almost always we have to make small adjustments to make sure we get right along the bottom of the metaphyseal flare. And that is the final target. So we'll lesion here, the same thing. We'll lesion at 2 minutes and 45 seconds for a total of 2 minutes and 30-second burn. And we do it at 60 degrees C, which translates into the same 80 to 85 degrees soft tissue temperature. And so we've got the superior and inferior genicular nerves. The lateral one we don't worry about because of concerns for the common perineal nerve. And the subpatellar plexus. This is branches of the obturator nerve that gives rise to the subpatellar plexus that goes into the superior recess of the patella. This is the greatest amount, where the greatest amount of fluid will live. And so the same indications for here. This is patients that have failed non-surgical management. Most of the time, I do not perform a block, but that's just my own practice. The conventional recommendation is that you do form a block, use half a cc to 1 cc of lidocaine or stronger bupivacaine, and the patient has to get at least 50% pain relief. And then they're a candidate for it. Patients that have had arthroplasty, persistently painful, patients that have knee arthritis or knee pain that's not responsive to conservative management, patients that have too many comorbidities or don't want to undergo an arthroplasty are candidates for this. And for hip versus knee, this is genicular nerve. RF will be the bulk of your practice. If you're doing joint RF, I do shoulder, I do hip and knee, and by far the most common type of peripheral nerve RF lesion that we do will be genicular. We do this very frequently.
That's great, Doug. Do you always use all 4 targets, or are there times where you may use 1 or 2?
I always use all 4. Again, so same with the hip and the knee. So I'll use the medial metaphysis as an example. So I'll do one burn here, and I will make small adjustments, and I will make another burn a little bit inferior to that, right about here. So if you do angiography of the knee, you'll find the neurovascular bundle runs in differing positions. So in some of the salient work originally done, the anatomic work that was originally done, the nerve position here is slightly variable. So and also if the bones are a little bit more gracile, some people have a very notched metaphysis. Some people will have a more gracile metaphysis, and this is a good example of this. So is the bottom of the metaphyseal flare, the nadir of the metaphysis, is it here, or is it here? Or is it maybe up here a little bit? And sometimes if it's a little bit more of a gracile slope to the metaphysis, it's very difficult to determine where it is. Same with the medial. The bottom, the nerve might run here and it might run here. So my convention is doing 2 burns at each location and all 4 burns at the same time. Now, the subpatellar plexus area, this will often be omitted. And so I've always done this. And based on my non-randomized, non-placebo controlled study of my own opinion, this appears to be okay. I just want to err on the side. There's not been a study comparing 4 versus 3 lesions in the knee, but I just think that the subpatellar plexus contributes a lot to it. The greatest amount of capsule, and the innervation of the capsule is profound. The greatest amount of capsule is the superior recess of the knee.
That's great. For me personally, I usually do 4 needles, but I do ask patients if they have subpatellar pain, and that's where I definitely will do the 4th needle. If I have a patient who comes in and it's just infrapatellar branch of the saphenous, just the medial inferior portion of their knee, I'm just doing that 1 lesion. So even though we want you to learn the 4 target points, you may choose to use less depending on the situation. But for the most part, I am doing all 4. Any questions? Yes.
How frequent can and will you repeat this?
So Doug, the question was, how frequent can you and will you repeat this?
So we're really looking for about a year worth of pain relief. And if I get shy of 6 months, then I won't repeat it. If I can get 6 months to a year or more, then I'll do it. And I think I heard you make the comment that sometimes you get many years of pain relief out of this. Arthritis is kind of a wax and wane in terms of symptomatology. Arthritis never goes away, to be clear, and sometimes patients have symptoms, sometimes they don't. And if you can just shepherd them through their symptomatology, a lot of times I'll have patients come back 2 or 3 years later for this. But if it's proximal to 6 months, if the pain duration of relief is less than that, then I don't repeat it. I'm looking for at least 6. There are certain exceptions, okay? So if somebody has no other option, they're getting 4 months relief, too many comorbidities for an arthroplasty, they maybe had multiple revision arthroplasties and they can't so this is within reason, and it's your call as to what to do that, but that's my general rule.
I think this is a question that always comes back to the money and the medicine. So physiologically, there's no limitation on doing this procedure every week if you wanted to, really. It's relatively safe, but you can't, okay? Because your payer is going to go, what the hell are you doing this 52 times a year? So like Doug said, for CMS, we generally want to limit it to 1 per year, maybe 2 depending on your local coverage determination. But you really, what we want you to take away from all of this is really justifying the reasons why you're doing your procedures. Because everything you guys do will reflect on our whole field. So if you're willy-nilly doing crazy stuff, a payer's gonna go, what the heck's this guy doing? And then they'll say, we're gonna shut down reimbursement. And then you won't be able to do this. One of the things right now with this particular procedure is that it's right now undergoing utilization committee review. So the hope, and it may work for benefit, it may not, is that it gets its own CPT code, which will allow for reimbursement, of course, and depending on which facility you do it, whether it's a surgery center or will it be relegated to the hospital. So these are actually surveys we, like Doug, myself, Glenn, we're all filling out right now. So our societies send out surveys, they ask us how much work is involved, how technically challenging is it, what are the complications, and that determines how many dollars come out after you do the procedure. So to your question, you tell patients you can do it more frequently, but it really depends on your payer, what they will allow. And one of the things you're going to have to learn is how to appeal when they do deny, because even though there's level 1 evidence for a lot of the stuff we're doing, and that Tim Davis paper is a great example for the knee, the insurers, they may scoff at it. You may present it to them, you may show them the data, and they still may say, when we calculate everything, it's still not worth it to us, even though there's a perfectly medical justifiable reason for it. So do the work in appealing, get on the phone, because it's really easy for them to say no. And I know it's a lot of work and it's a lot of effort to take the time to call these people and argue, but that's the only way these procedures are still within our armamentarium and that we get paid the right amount. Doug, any comments on that?
Just one further comment. I would really encourage you guys to be as capable as you possibly can be. So people say, well, I do viscosupplementation or I do injections and then it's off to arthroplasty. What I'd encourage you to do is do everything. Be facile with conservative, just medication management. Also be facile to know that you can have steroid injections are fine. The stepwise, typically we'll start off with that, go to viscosupplementation.
Other way, Doug.
And then after that, usually a long-acting steroid, a new medication called Zilretta, long-acting Kenalog. After this, radiofrequency ablation, and then arthroplasty, and be able to come back. Once you've done arthroplasty, you can't really inject particulate steroid into the joint replacement anymore, so many of the injections are out. So what you're left with really for post-arthroplasty pain is primarily and really exclusively genicular radiofrequency lesioning. So just be capable and know how these are applied, apply them in a stepwise manner, and knowing that you can always come back to one that's viable.
And I'll add DRG stimulation.
Time a little bit. Here in the state of Washington right now, that has health technology.
Hi. Okay. So here in the state of Washington, the Health Technology Assessment Committee is looking at neurodestructive techniques right at this moment. So if you live in the state, you need to have had your letter in already to them about this. And what I would encourage you, in addition to arguing with each individual patient, is to figure out who your major insurers are and figure out how they make their decisions and talk to them. The way they look at this evidence is not the way that people who do procedures look at this evidence. They think about it like their version of level 1 evidence is blinded, placebo-controlled randomized, hundreds of patients, quality of life assessments, independent people assessing the outcomes, a bunch of things that really we don't meet very often, in all honesty. So that's their standard, and they ignore fantastic case series. They ignore a lot of things that we think are valid, persuasive bits of evidence. They often will completely ignore that. So you need to be kind of at the influence stage to try to get it to be, in addition to doing each individual patient. And also, if you look at the data are more convincing for knees than for other joints, for sure. And you'll have an easier time with knees. Even with that, sometimes they will pay repeatedly for injections, like you inject at the nerves that you're going to target, but they won't pay for you to do a neurodestructive technique depending on the provider. So it's a weird environment in which we live with some of these things.
Those are great points. I'd encourage you to do diagnostic blocks, especially as you're starting out. Maybe Doug doesn't do it because he's got a good idea, and he's got the documentation, you get everything paid for, but what we don't want to see is that this procedure is done randomly and you're not getting good outcomes, because that's going to impact all of us. So use sort of the same standards as you would for, you're going to hear all about medial branch neurotomy. You have to do a diagnostic block, sometimes twice, depending on where you live. I do one diagnostic block for all my procedures, and for my geniculars, and if I don't, there's a medical justification for it. So I get patients with Alzheimer's who can't tell me how they're doing, right? They forget right away. The average age in Marin, I'm joking here, but it's like 90 years old. I see a lot of geriatric patients here are in Marin. And so I'll write in my note, we can't do a diagnostic block because they're not going to be able to report their pain scores. And so what we're looking to do is proceed directly with the radiofrequency ablation and hope that there's a functional perceived outcome from the caretakers. So again, justify everything you do, document it all.
What do you use for your blocks?
So I use 0.5 mils and 0.5% lidocaine. I do 25 gauge pricks. So that's not so uncomfortable for the patients. No sedation. Do them in my office. As Brett said, they may cover that diagnostic block, but they may not cover the next step, the radiofrequency ablation. So understand, like I have a table in my office, so Blue Cross does not approve unless you meet this. Blue Shield, Anthem, Cigna. So you guys should all do this. I know it's. Oh, is this not on? Oh, sorry. Oh, maybe I turned it off. Sorry. So there's not interference. Yeah, I encourage you to really understand all these caveats for each insurer. I know it's a pain in the butt, and it's the last thing you want to think about. You're like, I'm supposed to be a pain physician, I'm supposed to be a doctor, why am I dealing with all this stuff? But it is our reality. There's nothing more heartbreaking, and I've been guilty of this too, where I've done the diagnostic block and the patient's like, this is amazing, and then we want to do the RF and it's not approved. So that hurts the patient, that hurts you, et cetera. To Brett's point, there's an HMO in our area that just found this to be like crazy experimental. There wasn't really a lot of newer pain stuff being done when I went into private practice about a year ago. And basically a few of the physicians I worked with were like, we know the CMO for that network. Here's their phone number, cell phone. So I called him right up, talked to him, and he's like, yeah, sounds cool. Great alternative. Okay, great. And every HMO patient has approved this RFA at 1.3 Medicare, which is pretty decent for an HMO. So, you do have to make these phone calls. Maybe you waste more time, as you said, Brett, talking to each individual peer-to-peer, but you still got to do it. Work your way up the insurance ladders. And sometimes, the card I throw down is have those patients call the insurance board for your state. If they're denying them a potentially good therapy that negates their need for opioids, for example, or allows them to function and work or do things at home.
And it also encourages you to know the literature. So you need to know the literature behind what you do and the reasons why. So a medical director can ask you, well, doctor, why do you want to do this? And you need to have a good answer. You need to have a good answer first for yourself and for the patient while you're doing it. And then you need to be able to translate that over to the medical director. And if you do have a good answer while you're doing it, it's an easy conversation.
The other thing you'll discover is if you do this is that some of them are, if any of you have seen the movie The Secret Life of Walter Mitty, the guy that comes in to close the company down, he's just there to say no and close everything down. Some of them are just there to say no. And no matter what you say, they will say no. Others really do care about the patients and really do want to provide good care. And those people are the ones that will listen to the arguments. And you need to be ready to go with those folks and convince them. And so it's two things, knowing the literature, but also knowing your patient and say, you know, you guys have paid for this in the last year and a half for the patient, and this other alternative is this, and I'm offering you something different. And sometimes they will listen to that, but if you do enough of these, you'll discover that there's the reasonable people, and then the no, people just say no.
And I'll add to Doug's point, I keep a huge file of all the studies for basically every condition, procedure, so that if a CMO does ask me for the studies, I just, boom, send them that folder. So for genicular, like I said, the Tim Davis study, and then before that, there were the proof of concept studies. So I just send them that whole file. Sometimes they're overwhelmed. Like you show them the spinal cord stimulator data, and they're just like, gee, good God, there are like 60 articles here. So that's good, you know, we need more evidence. And that's the only way to speak, right? Just being cozy isn't enough anymore.
Yeah, the best study for genicular radiofrequency ablation is Tim Davis's double-arm randomized control trial. So this is comparing genicular RF with steroid injections. It's a good level 1 paper, and it's essential to know, and it's even better to have it at your fingertips.
Any other questions at all? Yes.
Well, what I learned, like the QRF, unless you do it in a hospital setting, they're not going to reimburse the kit itself.
Right.
So is that how you guys are doing it in the hospital, surgical center setting?
Right. So maybe I'll just answer this for you, Doug, rather than repeating it. So the cost for the kit, it is way more expensive than your traditional, needle and reusable probes. There's no question about that. So the reimbursement currently in an ASC doesn't justify its use. But that doesn't mean you can't do these procedures in an ASC. So if you are doing, for example, sacroiliac joint RFA with the L5 and L4 dorsal ramus, well, that's 64635 and 64636 do pay a lot. That's your medial branch neurotomy, which you guys are going to hear all about, right? That with your lateral branch RFA other nerve 64640 justifies the cost of that kit, but also is your major way to make money doing that procedure. So your knees might be a loss leader for your ASC, but here's the thing. The reason I do this is because it's great marketing. I personally do most of these in the hospital setting, so I have one day at Marine General Hospital where I'm doing all my cooled RFs, but there's a surgery center that bought a cooled RF machine, and they do accept some knees and hips, knowing that it's gonna be a loss for them, but it's good marketing. You're getting athletes, you're getting people who are staving off surgery, you're getting them off of opioids, and you look online for cooled radiofrequency ablation in my area, and my name comes right up. Or I'm sure if you're in Doug's area, his name comes up. So to me, it's an important tool, and it's something not many other physicians are doing that keeps me kind of separate. But great question. That CPT development with RUC that's going to come up may change that, right? So reimbursement may be good enough where we're going to see this more in the surgery center. That's certainly what Halyard Avanos wants. This is a surgery center procedure. It should be done there, but we just have to balance out the money.
So we're happy to have James helping us today, and also Mike Dana, who I was talking with about training courses. He just mentioned there was a training course out here with 21 people. So there are lots of training courses. I would encourage you to go to them, sponsored by Avanos. I've done numerous ones, and they're excellent training courses, and they're available throughout the country. So just ask either James or Mike here. They'll be able to turn you on to one in your area soon.
That's a great point. I'm teaching the one in Phoenix December 1st, so if you guys are in the area, keep in contact with the reps. There are a lot of training opportunities for STIM, for pump, for this, for everything. So great point, Doug.